Hello, my name is Michael Amon. I'm a third-year osteopathic medical student at H.D. Still University School of Osteopathic Medicine in Arizona. And today we're going to talk about GERD in pediatric patients. So, gastric esophageal reflux, or GERD, is a relatively common complaint in infants. Up to 10% of children still are affected by the disease at 1 year of age. The disease process involves upward movement of stomach contents, including gastric acid through the lower esophageal sphincter, up through the esophagus and out through the mouth. This can be in the form of mild spit up or at times excessive repetitive vomiting. Some causes of GERD in infants include problems affecting their nerves, specifically the vagus nerve, cranial nerve number 10, problems with the brainstem, poorly coordinated gastrointestinal tract, inability to control GI muscles, and relaxed esophageal sphincter. Some symptoms of GERD include frequent vomiting, persistent cough, wheezing, refusing to eat or drink, gas and colicky behavior due to abdominal pain, associated with frequent crying and fussiness with feeding or immediately after feeding, and of course regurgitation. Some non-OMT methods of treatment for gastroesophageal reflux disease in pediatric patients include elevating the head of the baby's crib, holding the baby upright for 30 minutes after feeding, thickening the bottle feeding with cereal, feeding the baby smaller amounts of food more often, and medications such as proton pump inhibitors like omeprazole. So let's talk about the physiology of the vagus nerve. The vagus nerve, cranial nerve 10, increases stomach acid production through 3 different pathways. The most direct pathway occurs as the vagus nerve releases acetylcholine directly at the gastric parietal cells, causing the parietal cell to release hydrochloric acid. The vagus nerve also stimulates G cells in the stomach. This stimulation causes secretion of gastrin, which binds to the CCK receptors in the parietal cells and subsequently causes an increase in hydrochloric acid secretion. The third and strongest pathway occurs when the vagus nerve stimulates the enterochromaffin-like cells in the stomach. These cells secrete histamine, which binds to H2 receptors on the parietal cells. This also causes the parietal cells to release hydrochloric acid. The vagus nerve passes through the jugular foramen in the skull, along with cranial nerves number 9 and 11. Somatic dysfunction between the occiput and the temporal bones can affect the vagus nerve as it traverses through this path. Therefore, OMT treatment at the base of the skull can reduce the stomach acidity and gastroesophageal reflux with a simple occipital condylar decompression. So my helper today is Aria. She'll be helping demonstrate these techniques. She's currently 4 years old. However, when she was an infant, she was also affected by GERD with excessive vomiting, post-feeding, and visible stomach irritability. The first procedure we're going to do is the occipital condylar decompression. This is a very tolerable and relaxing indirect treatment that can normalize the impulsivity of the vagus nerve and decrease hydrochloric acid production in the stomach. During this treatment, the patient is laying supine at the table, while the physician is seated at the head of the table. So Ari, I'm going to come up here. I just want you to lay real still and relaxed. Okay. The physician places the index fingers on the occiput as close to the occipital condyles as possible. Okay, lean your head back. The physician's hands and arms should be supported on the table. The tension is applied in an anterolateral position. The physician can apply a lateral tension force by moving the elbows immediately. This causes the fingers to move laterally and widens the foramen magnum, decompressing the tension on the occiput and the occipital condyles. The physician holds this position until a release is felt. There's a change in the tissue texture, there's a warming of the tissue, where the patient starts to take deeper breaths. You hold this position until you feel that sensation, and then afterwards you reassess. Very good, Aria. Oh, we got one more. So the next is the esophagus. The esophagus exits the abdominal cavity and enters the thoracic cavity through the abdominal diaphragm at the level of T10. Somatic dysfunction of the diaphragm and the opening in which the esophagus passes can cause issues with reflux as well. Thoracic abdominal diaphragm redoming can aid in reconstructing normal structure and function of this passageway. Thoracic abdominal diaphragm redoming. This procedure is also a well-tolerated indirect technique. The patient is again positioned supine on the table. Almost, baby. Because we'll see in just a minute. The physician stands to the side of the table and places the hands at the lateral sides of the patient's rib cage with the palms and the fingers spread. Just like so. Just relax. The physician carries the rib cage into right and left rotation to a point of balance. Next, the physician introduces right and left side bending and flexion and extension until a point of balance. And will continue until release is felt. Is this better? Okay, good. Okay, once a point of balance is felt, you'll reassess the patient.
Are you done, Daddy?
Just a minute. So, contraindications for these procedures. Both procedures are gentle and indirect procedures and are very safe. The relative contraindications are infection and trauma, and absolute contraindications are if the parent or the patient refuses. And that concludes. Thank you.